The problem with managing inflammatory bowel disease, particularly with Crohn's disease, is that the relapsing and remitting nature of the disease hides the true nature of the progressive nature that we have seen over time. And if we just treat the flares that we see the disease progress with, over time, increasing amounts of bowel damage that is then irreversible. And this is something we have learnt to our cost over time by undertreating our patients. I'll start with a brief case. This is a young lady who presents with a relatively modest history of what turns out to be a pancolitis with Crohn's disease of moderate activity at presentation. You can see the symptoms listed up here. You can see her colonoscopy. She has a moderate inflammatory response. Biopsies confirm that she has colonic Crohn's disease. She is treated with steroids. You do an appropriate assessment, which looks at a symptom score. You look at her CRP. You look at her calprotectin. You look at week 4. That's the appropriate time to assess response to steroids. Is she responding? Yes. You can see that all the values have dropped by about 50%. So that's good. If she hadn't been at that point, you need to use another induction agent to get her well. At week 8, she is responding. She is off steroids. By week 14, she is completely well. Follow her over time. Be confident and leave her on no maintenance therapy. That would be appropriate for someone like this. Calprotectin, symptoms, CRP, probably every 2 to 3 months for that first year. She does well. So not everyone with Crohn's disease has a complicated course. There are at least a significant proportion of patients like this, maybe up to a third, who will do fine initially. But we know that the majority of patients with Crohn's disease will have a relapsing or remitting disease course. And these are the people in whom, if we undertreat them, particularly if we undertreat early, and if we use ineffective drugs, we won't be able to get them into full remission. So this is the problem. Diagnosis of Crohn's disease, induced remission, triggering events that are causing disease to flare. It flares multiple times, and over time that means the disease evolves with progressive bowel damage that we can't deal with. So let's go back to a variation of that initial animation. We need to get under the skin of the inflammation, of the symptomatic flares. Because if we look beneath the symptoms, we also see the inflammation that's burning away. And even when people are well or symptom-free, in a significant proportion of patients, there will still be burning inflammation that's present. And if we just treat the symptoms and we don't get under the skin and also treat the inflammation, then we'll never have the opportunity to alter the natural history of the disease. So, treat properly, we can do away potentially with the evolution of disease. We still then perhaps left with relapsing and remitting disease. If we can get rid of the relapsing and remitting disease completely, well then that starts to become very, very attractive indeed. I believe that we are unfortunately quite a long way away from curing inflammatory bowel disease and a long way away from preventing it from happening in the first place. We know too little about what causes it to happen. We don't have biomarkers for early disease, nor do we know how to intervene. You know, we can't get Dan to give everyone in Scotland a fecal transplant every day for the rest of their lives if they're in an at-risk state. But perhaps, if we can identify things properly at diagnosis, stratify our patients by risk and biology, we can induce remission quickly, we can induce remission completely, prevent the disease from flaring, and then that would be really quite transformative for our people with inflammatory bowel disease over time. So, let's see what that looks like, and let's see what we can do about that. Well, Dan alluded to that I would mention a slide on the PREDICT study. I couldn't possibly not do that. This is a major effort across Scotland, now expanding into England, to try and ascertain what the cause of disease flare is. So hopefully that we can actually then intervene to prevent the disease from flaring. We've recruited well over 1,000 people to date, mostly from Edinburgh and Glasgow, so thanks very much for everyone that's taken part, but also Dundee, Aberdeen and Inverness. And we're doing this very detailed survey to try and understand what dietary, what environmental, what lifestyle factors, as well as what factors within the microbiome cause disease flare, so that we have really, really high quality prospective evidence that will allow us to target our interventions more specifically. And it's wonderful in Scotland that if we've got the mechanisms by which we can do interventional dietary studies, like Dan's talked about, interventional microbiome studies, then we can combine forces to look at this in some detail. So that's futurescaping, that's where we're going. Where are we going in the short term? Where are we going in the short to medium term to try and address this? Where are we going to try and get our patients to here, to a state of prolonged remission from here, which is diagnosis? So we have failed as a translational community to get you, as the clinicians, a better understanding of how we stratify our patients by risk and by biology. Because this is the fundamental thing that determines the treatment choice that is going to affect the outcomes. What this has meant is that we've had to largely flip a coin about which drug treatment we've used. We've been in a reactive rather than in a proactive state, and it has meant that we've been stuck in this monitoring loop. As a result, we've had to get very, very good at monitoring, and it's a relief that we've got tools now that enable us to do that with calprotectin, with TDM, as Jonathan's been talking about, to try and improve that loop. Now, this is important because we do now have treatments for Crohn's disease and ulcerative colitis that work. They don't work for everyone, but they do work for a significant proportion of patients. And we're getting much better at knowing when to use them and how to use them and in whom. And the very simple answer to that is give more drug to more people earlier in the disease course. But of course, as I alluded to with that initial case, it's not going to be needed for everyone. And of course, in a cash-strapped health economy like the NHS, we can't afford to do that either. So these drugs, these 4 drugs that we have available to us, adalimumab, infliximab, Vedo and ustekinumab, with tofacitinib coming very soon to add to this, work in these parameters that we have seen across the side here. So here's another case that illustrates how we might use these drugs. Here's a patient of mine who presents quite a few years ago now with what turns out to be multifocal small bowel Crohn's disease. You can see a classic history here of postprandial abdominal pain, weight loss, a very robust inflammatory response with an iron deficiency anemia. You can see the CRP's up, you can see the calprotectin's pretty high. People like this I put onto exclusive enteral nutrition to start with in the clinic, because it's going to take at least 4 weeks in Edinburgh to get him scoped, biopsies back, and an MRI, and that's with a good wind. But you do those tests, you do your endoscopy, you take your biopsies, you do your MR enterography, and you find multifocal small bowel Crohn's disease. He has a full house, really, of risk factors. You know that this chap needs intervening early, and in this kind of situation, a top-down approach, I think, is very, very appropriate. Going in with our most effective drug combination to start with, avoiding toxicity of steroids, inducing remission, inducing deep remission, doing that early, and then monitoring tightly over time to keep him in the target that you're treating to so that you're avoiding the complications of disease. So to treat effectively, we need to do those things at the start, but we also need to know what we're treating towards, and this has evolved over time, and this is now becoming what we would call a treat-to-target algorithm. So it's worth just bearing in mind that for 40 or 50 years, all we've been aiming for is clinical remission. But actually, for a large chunk of that time, that was all we could achieve because we didn't have drug treatments that could get us beyond just simply clinical remission. So you can see, we've been using steroids since the 50s. Thiopurine's actually first reported use in the 60s. And it's only in the last 20 years that we've been using these other drugs. So we should bear in mind, particularly for Crohn's disease, that mesalazines and steroids will not get us to the targets that we want. They won't even induce proper steroid-free remission. So now our targets can evolve, now that we have more drugs that will help us to get into these targets on the left. So long-term remission, deep remission, and therefore reducing bowel damage over time. So the target has evolved, and this is now allowing us to adopt a treat-to-target approach. What is the target? Well, the STRIDE consortium, which is an international consortium of key opinion leaders, has determined the target for both Crohn's disease and ulcerative colitis, and the target harks back to what I told you at the start. The target is to get someone well and to get their bowel healed. So no symptoms, no inflammation. And by doing that, we know that we can change what happens to patients over time. And you'll see a similar thing for ulcerative colitis too. The details are listed in here, But actually that's the most important thing. Our target is to get rid of the inflammation and to get rid of the symptoms, and that's what we should be telling our patients too. So here's a simple schematic of when we might use the biologics and how we might use our treatments in Crohn's disease. So patients on the left with mild disease, what we might be looking for is a one-off course of steroids and then leave them on nothing, like I said at the start. People with severe disease, your classic hospitalized patient with very sick colon, with acute severe colitis, Crohn's disease or ulcerative colitis, I think, we're going down a top-line therapy route with those people. We're doing this already. We've been doing it for a while in the hospitalized setting and in others. But most people fit in the middle here somewhere. And this is where we need to get much better at how we're going to identify those people who have risk factors to determine what we do. Because those people with moderate disease with risk factors, almost certainly we should be treating them either with a very, very aggressive step-up algorithm with monitoring to get them on the effective treatment early, or with a top-down approach. But because our limited prognostic ability, that crystal ball for IBD that's just non-existent, we've had to get very good at monitoring so we can appropriately and early get people onto effective treatment. I'm going to suggest to you that with the advent of biosimilars and a reduction in cost quite significantly, those patients that would previously have gone on to thiopurine monotherapy are now very likely to go on to an anti-TNF monotherapy-based approach, but that's something perhaps to hold for the discussion. So what are those risk factors? These are the Bogerie criteria. The Bogerie criteria were first presented at DDW 20 years ago, and they don't really help us. We should use them, and we should use the ones that are relevant. So, extensive small bowel disease, perianal disease, absolutely. People with fistulizing perianal disease, please do not just start them on a thiopurine or a mesalazine or give them a course of steroids. These people deserve effective therapy early, and they need higher doses. They need higher serum concentrations of the drug if we're ever going to heal their fistulae. Weight loss, deep ulcers, but not steroids at diagnosis, not young age, not smoking, because actually these factors don't help us distinguish between the groups. And so it's with big prospective cohorts that we're going to start to get a little bit better at working out how we can make sense of this potpourri. And this is only going to get more complicated rather than less as we have, thankfully, more tools in our therapeutic toolkit. So we have anti-TNF monotherapy versus anti-TNF combo therapy. And some of the data from the PANTS cohort that I probably won't share with you today, but are giving us some of the information that are starting to help us make these decisions about monotherapy versus combo therapy. For now, the very simple rule of thumb is that by and large, for the vast majority of people with IBD, you should be giving them combination therapy rather than monotherapy. It's more effective and it prevents immunogenicity in a significant chunk of people. Immunogenicity is what drives loss of response. Loss of response is the single biggest risk factor of anti-TNF therapy. Because if you have Crohn's disease and you fail anti-TNF therapy, any other therapy that you get, be it ustekinumab, be it vedolizumab, be it a JAK inhibitor, or any of the new drugs that are coming through trials, if you're a TNF failure, your chance of mucosal healing at 52 weeks is 10%. And that's pretty lousy. We don't yet know if these are a more treatment refractory group of patients or whether or not there is an immune shift conferred by the anti-TNF therapy. And the answer is probably somewhere in the middle. So Jonathan's given us a very, very nice illustration of how we should use TDM to optimize our drug therapies. We should be doing this, but combination therapy is the right way around that. It remains slightly vexed, but it's an important thing to do. Let me just shift this around a little bit now to make this very, very practical about what we're going to do in terms of optimizing our patients' quality of life. So the y-axis here is quality of life. Before diagnosis, normal quality of life. At diagnosis, quality of life hits the bottom. This is what we've done for too long. Pulsed courses of steroids, making ourselves and the patients feel a little bit better, but we've not actually managed to get patients properly better. We've then initiated a drug late with adherence challenges and other things along the way. We've only managed to get people a little bit better. This is what we should be doing, I think, is where people are at risk, we should be intervening early so that actually we can get our patients back to that normal quality of life where they should be down the line. And the ways that we do that, the ways that we stop that slump down the bottom so that we can't get our patients properly better, is that we get them into our clinics early. That makes a difference. We then diagnose them appropriately and early. We monitor regularly, and we don't just monitor. We monitor, and we act on the results of the monitoring. So we can now do this. We can do it by looking at symptoms, we can look by looking at the CRP, we can look at chiropractic, we can look at endoscopy. And we now have enough data to support the treatment paradigm, which is that if your patient is relatively free of symptoms but has significant endoscopic activity or significant inflammatory activity based on the calprotectin, you change what you are doing, because if you do not, that patient will run into trouble down the line. You do that, we're going to get our patients back to where we need to be. So this is the whole rationale behind a treat-to-target approach, and this determines our whole treatment strategy for patients with IBD, particularly when we're using biologics. So we assess the risk factors, we set our appropriate target, we treat in a timely manner, we monitor, and then we adjust as needed on the basis of the monitoring. I won't go through this in any detail, but just to say that this is something that we have stolen from the rheumatologist. This is a strategy that works across multiple disease areas. And it should now work in IBD. We know that with biologic drugs, we can decrease important events like surgical rates here for Crohn's disease pre and post the introduction of biologics. So what does it look like? Let's go through the practical steps again. From active disease to our treatment target. And I've told you what the target is. Assess risk factors, set the appropriate target, do that with your patient, do it in a timely manner, monitor regularly, optimize as you need to. If you haven't got there, change what you're doing. If you have got there, you don't just stop. We monitor our patients and we keep them in that loop. Now, just a brief aside, this is relatively straightforward now for us, for our patients on biologics. We have the IBD nurses, we have the pharmacists, we have home care, we have systems in place, we have a relatively manageable number of patients, maybe in Edinburgh, 600, 700, 800 patients on biologics, similar numbers probably at each of the major sites across the country. But in Edinburgh, we have 10,000 people living with IBD in some stage or other, and the people that worry me in terms of how we look after them through this kind of algorithm are the people that aren't on biologics, the people that come to the clinic once or twice a year or never. And we don't have a very good way at the moment of implementing this kind of treatment strategy with them. So my advice for us is that what we do for now is that we try and keep hold of this bigger picture as in part aspirational, but in the meantime what we do is we monitor our biologics patients closely, and perhaps we implement this much more strictly in our newly diagnosed patients, because those are the patients in whom, when we intervene appropriately, we can make the biggest difference in terms of improving their outcomes. So these are the things I've talked to you about again. I'm just showing them further so that you can see how this strategy can help to get our patients back to where they need to get to. Why do we treat early? Well, our drugs for IBD are anti-inflammation drugs. At the moment, we don't have drugs that do anything other than target the inflammation. They do it very, very broadly, like steroids, more narrowly, like anti-TNF drugs, even more specifically, like ustekinumab or vedolizumab. But they're all anti-inflammation drugs. So if we use them when patients have had disease for many, many, many years, and what they have is fibrosis and fistulae, then our anti-inflammation drugs are much less effective. So that's why we talk about this inflammatory window of opportunity. And the data support this very, very strongly now. Treat early, you will get better outcomes. You see this for all the drugs. This is just the data for anti-TNF therapy. You can see how many data points there are on the graph now. And you can see very clearly, I think, that in terms of clinical remission rates, you go from high clinical remission rates at very early use to much lower clinical remission rates when you've used the drug for a period of time. Roughly about 2 years is what comes in here, but actually for many patients, the cutoff will be earlier and earlier. And this isn't just data from the big Western centres. This is data that I won't go into from Korea that shows the same thing emerging in that data set there. So this is the rationale, and this is the algorithm, the sort of schematic for a treat-to-target approach in IBD. We now have good data to support that. We now have data from CALM, from REACT, and from POCA. And I'll just very briefly highlight the key messages from CALM here. CALM's an important study because it's the first study that, in a randomized controlled manner, looked at treat to target by optimizing drug treatment based on not just symptoms and a symptom score, but also on biomarkers, CRP and calprotectin, versus just optimizing treatment based on symptoms. So forget what treatments we used. This is an anti-TNF-based strategy, but that's not so important. The important thing here is that when you optimize treatment based on biomarkers and scoring, rather than just a loose thing, you improved outcomes. And you improved hard outcomes. The endpoint at a year was mucosal healing. So tight control patients doing much better than those on a just simple clinical management algorithm. And you can look across a whole raft of different endpoints at a year to see that this was observed throughout. REACT and POCA, I won't go through in the interest of time, but these studies also demonstrated the same thing. Treat to target with POCA in a post-operative setting, you do much better. We've got quite good at doing that now. And REACT was also a data set that showed that just by a symptom-based scoring system, you could improve hard endpoints at 24 months to time. So there are other things I want to tell you about, but what I'm going to do is I'm going to finish just by highlighting this checklist so that we can have plenty of time for Morag's case and for some questions later on. Treat to target is now, I think, the framework around which using biologics appropriately for people with IBD can be done in a manner that isn't just give everyone more drug early, but will allow us to give more drug early to the people that need it. And Jonathan has really hit the nail on the head there by saying that we will almost certainly not need to use more drug overall if we use more drug earlier in the people that need it. In fact, Marla Dubinsky's proactive TDM data shows that very, very clearly indeed. So, we need to continue the efforts across Scotland, which we have done much, much better about getting our patients into our clinic earlier. Calprotectin in primary care is just one of the ways in which that has been facilitated. Our treat to target approach, I think, is now very effectively based on symptoms, CRP, calprotectin, and then the judicious use of colonoscopy and MRE. Bringing our patients into this is very, very important. And I will just spend a few seconds talking about this. We have our IBD nurses that will help us talk about specific drugs and different parts of management and provider service. And we can outsource as clinicians some of the conversations to you about that. But there are some things that I don't outsource. And I spend more and more time with my patients at diagnosis to explain some key facets about the disease. I explain many of the things I've just talked to you about, that Crohn's disease in particular is progressive, that we don't have a very good crystal ball, so we're going to have to monitor. The problem with monitoring is that your symptoms aren't good enough because there will also be inflammation that we can't detect just by looking at your symptoms. The calprotectin is a really good way of looking at that. That's why we're going to ask you to poo in a pot, maybe every 2 or 3 months, and provide us a stool sample. It means that we don't have to do an endoscopy every 6 months. So patients get on board with you from that point of view. But most importantly, what I will say to them is my expectation is to get you well, is to get you completely well, and to protect your bowel for the long term. I don't actually know what treatment to give you right now, 100%. So I'm going to make my best educated estimate on the basis of all the information I have in front of me. I may get it wrong the first time. The first drug may not work. The second drug may make you sick with toxicity. The third drug may need quite significant optimization with increased doses, some adjustments around the edge. But if you stick with us along this process, we will aim to get you better. That stops the patients disengaging. It stops them going away and just relying completely on complementary medicines. It keeps them on board. It keeps them on side. And I think can make a big difference to how we improve things over time. So engage your patients. Assess the risk of disease progression as best you can. Treat in a timely manner. Okay? This is so important. Monitor the disease regularly. We've got the tools to do that very robustly now. But don't just monitor. Please don't just say, dear doctor, I note that the patient was well. I note again that the calprotectin is 500, but we're just going to blindly ignore that and carry on with our ineffective drug treatments. We have effective treatments. Let's use them and let's optimize our drugs appropriately.